Okay, we're going to talk about physical assessment now. There are 4 basic techniques we use in physical assessment. I see more and more comments from healthcare professionals on Twitter about not actually doing some of these things and relying on imaging or on labs. But realistically, you really get the best picture of the patient when you put your eyes and hands on the patient. So first of all is inspection. That's using vision, smell, and hearing. You want to expose the body part to be inspected. You can't inspect a chest wall with clothes on it, right? You always want to look before touching. You want to use good lighting for inspection. And you need to have a warm, comfortable temperature in the room. Heat and cold increase discomfort, but they also may change the appearance of the skin. You want to note things like the color of skin. If there are any abnormalities, you might note the size, location. You want to notice the texture of skin. You look at symmetry. Is your patient's face symmetrical? You might notice odors and sounds. So this is what you can observe about the patient without putting your hands on them. Okay, you can begin your assessment while you're talking with the patient, developing that relationship. Palpation is the use of touch. We should have short fingernails to work in healthcare. Make sure you're using the most sensitive parts of your hand for different types of assessment. Use your fingertips, not your thumb, for pulses. Fingertips also are better at fine discrimination. We're more able with our fingertips to assess differences in texture. The palmar surface is better at detecting vibration. So if we're going to maybe palpate a dialysis shunt for a thrill, use the palm. And the dorsal surface is usually more sensitive for temperature. Okay. We do light palpation before deep, and we don't always do deep palpation. Palpate tender areas last. We want to note texture, the temperature, moisture or dryness of that skin or tissue, tenderness, and the consistency of that tissue. Percussion is tapping body parts to elicit either tenderness or a variation in sound. When we do percussion, we can get an idea of the density of the underlying tissue. Okay. Direct percussion is usually used to elicit tenderness or pain. So we might tap over the kidneys very gently. And if they have flank tenderness, and they have tenderness to percussion, right? So we directly tap that body part with our fingers. Indirect percussion is used to elicit sounds from the chest or the abdomen. So I use the middle finger of my dominant hand, place it on whatever I'm percussing, and use the middle finger of my non-dominant. Use the middle finger of my dominant hand to tap. Okay, so if I'm over bone, that's going to sound flat. If I'm over soft tissue, that's going to sound kind of dull. If I'm over lungs that have air in them, that's going to sound a little bit more resonant, right? If I'm over intestines that are full of gas, that's going to sound tympanic. Okay, it's going to sound more tympany is like a loud high. So think about the sounds you get based on what is underneath that where you're percussing. Auscultation is using that stethoscope. Your stethoscope is an important nursing tool. It is part of your job. Listen to lung sounds using a stethoscope. Listen to heart sounds using a stethoscope. I saw a debate about bowel sounds on Twitter this week also, but as of right now, we want to listen to bowel sounds. Auscultation is listening for various sounds using a stethoscope. You want to auscultate over bare skin, the diaphragm. The flat side, that's usually bigger, needs to be used with firm pressure, and it can hear higher pitch sounds. The bell hears lower pitch sounds better, and it requires light pressure. When you're listening to lung sounds, compare symmetrical sides of the chest. Don't go down one side up the other, go back and forth. Another thing about lung auscultation is make sure that you are actually listening to all of the lung fields. I see a lot of people go into a patient's room, listen to right here, here and here, done. If someone has CHF, where are you going to hear those crackles? In the bases at the back or whatever side is dependent. If someone has pneumonia, you're going to hear that decreased breath sound, crackle, wheezes, where the pneumonia is located. So listen to all lung fields. Some general guidelines for assessment: provide privacy, inform the client about what you're going to do, okay, and inform the client what you notice. Have a planned order for each system. For most systems, we do inspection, palpation, percussion, and then auscultate. For the abdomen, we auscultate before we touch. So we inspect and then auscultate, then percuss and palpate. And that's because if I start poking around on your belly, it's going to affect peristalsis and we're going to have a change in bowel sounds. We want to expand on any abnormalities. If you notice anything unusual, assess further. What other questions do you have about that? Educate as you assess. Allow time for questions. So when you're assessing, make sure you're comparing symmetrical sides. Assess both structure and function. So you want to assess, so for the hand, are there any malformations? Is there any skin breakdown, things like that? But also, do they have movement of that hand? Do they have good sensation of that hand? Assess from head to toe. Further investigate any abnormal findings. I think I've said that about 3 times. That's very, very important. As you're doing your assessment, don't get so caught up on, I'm going to mark these things off, that you miss the cues. Okay, do you recognize what's going on with your patient? There are really detailed head to toe assessment instructions with normal and abnormal findings in your Weber assessment book. And that's the little spiral assessment book. It also has really detailed instructions for how to do a lot of specialized assessment. So I encourage you to use it a lot. And practice your assessment skills. Okay, practice, practice, practice. So there are different types of assessments. We've been talking about assessment as if we're going to do a full, complete history, everything that's ever happened to them, and head to toe assessment on every patient. But the reality is that we don't. We don't need to do that on our patient that came into the ER with chest pain, right? We need to know about their chest pain, and we need to know things that might affect going to the cath lab or whether they're having a heart attack, right? So triage assessment is used to determine how, more than anything, how quickly someone needs to be seen. So we have triage in the ER. The ER nurse assigns triage levels based on patient symptoms, presenting complaints, vital signs, okay? Triage in the ER is a skill set that you learn as an ER nurse, and you should be taught specifically how to do triage. We also have triage in like mass casualty incidents, which patients can be saved and how quickly do we need to take care of them to save them. So think of triage as what needs to be happen right now. So who is going to die first, basically. Quick priority assessment is once they're in that ER bed, the nurse does a quick assessment. What are my priorities of care? Okay. You might also see that in EMS. You do a triage assessment if you've got several patients, but when you have that one patient in front of you, you do a very quick, what's the highest priority? And I think of this again as what's going to kill them first. A complete database assessment is what we've been talking about, gathering all the information, give me all of it. A focused assessment is when we go back and we're focusing on just the systems that are affected. So if I admit a patient with pneumonia to an inpatient nursing unit, I want a full database assessment. I want their whole health history. I want to know what meds they take at home, what doctors they see, what surgeries they've had, everything they've ever had go wrong with every system. And then I want a full head to toe assessment. And then I'm not going to do that every shift, right? So then I come in and do a shift assessment on that patient, and I'm going to do a head to toe assessment, but I'm going to do a quick one, and I'm going to focus more intensively on the systems that are affected. So what if my head to toe assessment then shows up that wound on their heel? Then I'm going to go in and do a focused assessment on that skin breakdown. So that's a focused assessment. There are special needs assessments. Every patient that enters a healthcare facility gets a fall risk assessment. We can do nutritional assessments. We do pressure ulcer risk assessments on everyone. We do pain assessments, and there are multiple tools for measuring pain. I really don't ever want to see patient is unable to verbalize pain. That's not a pain assessment. If your patient is able to verbalize, you can work with a 1 to 10 scale. There are actually other self-reporting scales that are more specific, especially for chronic pain, but you can use a 1 to 10 if they're able to verbalize. If not, there is probably a scale for evaluating their behavior to determine whether they're likely in pain or not. And that's everyone from premature newborns to developmentally disabled or cognitively disabled adults. Okay, there are pain scales that are used that are appropriate for your patient. There is a way to assess your patient's pain. We might use depression scales, and some of you might have actually used other specific assessment tools that are aimed at assessing a particular issue. Okay, so this was a quick overview of assessment. You also have a video that is a demonstration of history and assessment.